So in this video, we're going to be discussing talocrural joint mobility assessment. As with most of our assessments and range of motion analysis, we need our patient to be in prone with the knee flexed. And from here, we're going to assess the resting signs and symptoms of our patient. Is there any pain? Is there any discomfort? Things along those lines. From here, we can then begin to assess the posterior and the anterior, or AP and PA glide of the talocrural joint. And so what we need to do is we need to stabilize the distal fib joint. And so we're looking here at the more distal portion. It's proximal to us, but distal with regards to anatomical positioning. And we're going to look first at the posterior aspect. And while we're doing this, we're assessing the arthrokinematic movement. And so we need to have our ability to take this beyond the first point of pain, really to the end range of the joint itself. So for posterior, we're going to use the web space of our mobilizing hand, which in this case is going to be my right hand. I'm going to provide an anterior to posteriorly directed, a posterior glide, if you will, to the talus, specifically through the neck of the talus. That force needs to be appropriate such that I, again, am finding in range. So the initial mobilization, or the assessment, if you will, mobilization would be the treatment. The assessment is going to take all the slack up to full end range, and then from there I can grade it into a 1, 2, 3, or 4. So what I find to be helpful is to kneel on the table next to the individual such that you can kind of stabilize their femur and the knee. From here, we're going to stabilize just proximal to the lateral malleolus with a firm grip. We're going to use that web space with kind of a V patterning. We're going to come right onto the neck of the talus, and then our hands are essentially going to oppose each other. We're going to do this. The stabilizing hand is not moving. The mobilizing or assessing hand is moving. This side is just going to stabilize, and so we're creating this motion here. So stabilize here, V or kind of this C grip right at the web space, neck of the talus, and then we need to be mindful of line of force. So my forearm is in line with the direction of force, and then we're going to assess that motion. Okay, full assessment, and then we can grade it to a grade 1, 2, 3, or 4. Conversely, we can also look at this in terms of an anterior, and so this would then be a motion of posterior to anterior. Same protocol exists, only now my hands change. My right hand becomes the stabilizing hand. My left hand is going to become the mobilizing hand. And so I'm still just proximal to my lateral malleolus. I'm going to stabilize with my right hand. I don't have to be so concerned of line of force here because I'm just stabilizing. I do have to be concerned of line of force with my left hand. Web space comes here. I do find it helpful to take up just a little bit of slack so that the Achilles tendon does not limit you in terms of range of motion. So if the individual comes into just a little bit of plantar flexion, that tension that exists at the distal Achilles tendon will essentially go on slack, and you'll be able to push through that. If they're in a dorsiflex position, it's very hard to push through that. You're going to encounter the Achilles. So slight plantar flexion, take up the slack, then you're going to stabilize with your opposite hand, and now provide that anterior motion or anterior glide. Full assessment, and then from there you can grade it into your different 1, 2, 3, and 4 mobilizations. The last arthrokinematic assessment that we want to look at the talocrural joint is talocrural distraction. Now with this, we first need to recognize that we're not just going to be distracting the talocrural joint. We're also going to be more proximal to the knee. So we need to make sure that there's no underlying pathology that may be existing here. Additionally, our knee is going to stabilize the proximal femur. Be careful that you're not pressing too hard. There are some sensitive neurovascular structures as well as soft tissue structures in that posterior space. From here, we're going to bring the tibia back to a vertical orientation. We're going to use the same grip that we used before. Find the neck of the talus. We're going to mirror that with our other hand, and both hands are going to go directly vertical or up towards the ceiling to provide a distracting force at the talocrural joint. And so it would look like this. Be mindful now that your line of force, my forearms need to be down. You can interlace your fingers on the opposite side, and then you're going to provide the distraction force. You can use your leg to kind of stand up. The arms really aren't doing much of the work here. Instead, it's my leg that is providing that upwardly directed force for talocrural distraction. Have a go of this with your peers and colleagues, and let me know if there's any questions.